Welcome to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, the Executive Director of Speaking of Women's Health, and I'm back in the Sunflower House for a new episode of the Speaking of Women's Health podcast. And it's May, which is Mother's Day, Nurse Appreciation Month, and Osteoporosis Awareness Month. And osteoporosis is a major problem. 1 in every 2 women by age 55 have osteoporosis. And as I tell all my patients, you don't want to outlive your bones. You don't want dowager's hump, wrist fractures, hip fractures. You don't want to shrink several inches so that your stomach and lungs and heart and internal organs are all compressed. So we thought what we would do for this podcast on osteoporosis in our second season, since in our first season, we had a couple of podcasts on osteoporosis, including the chapter on osteoporosis from my book, The Cleveland Clinic Guide to Menopause. If you missed that, you can go back and listen to that. Also, we interviewed an osteoporosis expert who trained with me several years ago, Dr. Christy Tuff DeSapri. So for this podcast, we thought we would do frequently asked questions about osteoporosis. And speaking of frequently asked questions, or just questions in general, in the past on our speakingofwomenshealth.com website, we had the ability for people to type in questions to ask the nurse questions. Now, unfortunately, our wonderful nurses are so overworked that I had to close down that feature because they're so busy taking care of our own patients in the Center for Specialized Women's Health. And I know that a lot of our patients will ask questions on Cleveland Clinic MyChart, their electronic medical record. But because that is time consuming, many times there's a charge associated with that. So that's one of the reasons we really want the most information that's accurate and unbiased and free and easily accessible out there on our social media, Speaking of Women's Health, our podcast that you're listening to, Speaking of Women's Health, on our Facebook and X and Pinterest and LinkedIn. And really, if you haven't already bookmarked speakingofwomenshealth.com, bookmark it on your iPad or your phone, smartphone, or your computer or laptop. Because anytime you have a question, go to the question box and ask the question. Or search for the information, and chances are you'll find the information. And if you don't, or you have a question that you might like us to cover on the podcast, please go on the Contact Us portion on the website and ask your question. And we'll try to incorporate those podcasts by myself. We also have our guest podcaster, the executive producer, Lee Kleckar, and we also have another guest podcaster, Sylvia Morrison. And our goal is really to get as much great content out to you, however you want to imbibe the information. Some people like to read. A lot of people like to listen. If you like to listen, but see the people that I'm interviewing, many of our podcasts are on our Rumble channel, which you can watch. And that's Speaking of Women's Health on Rumble. We also have podcasts on YouTube, although those are usually just the audio portion, just like any other podcast. But we do have other videos that you can actually watch on our Speaking of Women's Health channel on YouTube. So getting back to our topic, osteoporosis. May is Osteoporosis Awareness Month. So April showers bring May flowers. And May is just such a wonderful month. My granddaughter Beatrice is going to be turning 1 It's Mother's Day, which is always a perennial favorite for families. And also, it's a time to take some time to think about osteoporosis and bone health. And really, everyone needs to think about bone health because we all are supported by our hardworking skeleton. And osteoporosis is an elusive disease. And sadly, most people don't have any symptoms at all until they break a bone, which the medical term is fracture. But falling and breaking a bone is not a normal part of aging. And in most people over age 40, if they break a bone, it's not normal. It's a low trauma fragility fracture. Now, to anyone breaking a bone and having to go to the emergency room or getting a cast, or maybe even having orthopedic surgery, that's certainly a personal traumatic event for them. But that doesn't mean that it is a high impact, falling down several flights of stairs, car accident type of trauma. That being said, not everyone, even in traumatic situations, break bones. So that's why if you're over 40, man or woman, and you break a bone, it's a concern. Now you might say, oh, well, when I was a child, like I broke my wrist playing kickball. I think I actually had 2 injuries that day. And my uncle, who was an orthopedic surgical resident at George Washington in Washington, D.C., took me in and casted me. Children can break bones and it not be a sign of pathology because they have softer bones that are still rapidly growing. And that's the difference between a childhood fracture and an adult fracture. So osteoporosis is a disease. And like a lot of diseases associated with aging, it is both preventable and treatable. And it's so important to be proactive about your bones. And it's better to deal with it before you have serious disease. And that's why we're focusing on this for May Osteoporosis Awareness Month. So let's start talking about questions that you may have today. And as we mentioned, your skeleton is so important. And it's a complex living tissue. Most people are used to seeing skeletons at the time of Halloween, and the bones just look kind of old and inert. But they're actually very complex living tissue. And it protects vital organs, especially like your brain, the calvarium, your rib cage protects your chest and lungs. But the bones are metabolically active and they store calcium and other minerals that your bloodstream and the electrical systems in your heart and muscles need. So your skeleton is the bank, and your body's going to steal from that bank if you don't have enough calcium. And the bones break down and build up. It's a constant remodeling process. You may only remodel your house every couple decades, but your bones are breaking down and building up all the time. And it takes about 7 years to fully go through the regeneration of your skeleton. So from the time we're born until about age 30, we build up more bone than we break down. But after 35, there is a gradual outpacing of the bone breakdown compared to the buildup. So this leads to a gradual net loss. But at the time of menopause, midlife, for most women, it's a critical time for bone health. And the inside of the bones kind of resemble like a sponge. Now, when osteoporosis happens, there's holes in the spongy part and they grow larger and larger, and it weakens the internal structure of the bone. And for the last couple of years, in fact, I was the first at the Cleveland Clinic to get special software to look at trabecular bone scoring, which looks at the architecture of the bone, and it's classified either in terms of normal, partially degraded, or completely degraded. And that's about 40% of the bone strength, where 60% of the bone strength has to do with just the amount of calcium in the bone. So you can think you can have thick, dense bones, but if the architecture internally is not very good, you could still break bones. On the other hand, if you're a very light, thin, petite person your whole life, and you're just much lower average body weight than the average person, your bones don't have to be as big and heavy. And hence, as long as the architecture is really good, you may never break bones. But just like money in the bank, most of us would rather have more money in the bank to buoy us against any type of stressors or crises. And so people that have less bone genetically have less to lose. So it's good to know what your baseline bone structure in terms of calcium content and architecture. Now, if you are severely underweight and you have a BMI under 17, or you're quite overweight and have a BMI of over 37, then that's outside the limits of the machine to look at your bone architecture. In addition, people that are very heavy, especially in the midsection where we scan the lumbar spine, we're waiting for a software upgrade to help us deal with that skin thickness, because sometimes if the skin is so thick and the rays have to penetrate to get to the bone, it can look like things are a little degraded when they're not. So your risk for osteoporosis as an individual, in general, for a woman, the risk of hip fracture alone is generally equal to a woman's risk of developing breast cancer, uterine cancer, or ovarian cancer. And sadly, statistics show that almost 40% of seniors who have a hip fracture die within a year, either from complications of the fracture or the treatment, which many times requires open reduction and internal fixation with major orthopedic surgery, or just from being immobilized. If you don't move around, everything degenerates so much faster. That's why we always emphasize physical activity. And that's why it's so important in an older person to minimize immobility as much as possible. And those that do survive from a major hip fracture really run the risk, assuming they survive the fracture and survive the surgery, they run the risk of losing their independence. And most people that I know who are over age 65, they want to maintain their independence. They do not want to live in a place that's not their own home without their own things and their own family, even though for many people, starting in assisted living that has gradations of nursing care can actually be a wonderful choice and option. So now we're going to move on to the question portion. And you have been listening to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, back in the Sunflower House. We're talking all things May and osteoporosis. So the first question we got was, I recently learned that I have osteoporosis, and I want to know if you would recommend using a weighted vest, because I want to wear something heavier to increase my load on my spine. And I wonder if this is advised. Now, before I get to answering these questions, I want to remind everyone that this is not medical advice. This is an uplifting edutainment, educational podcast to empower our listeners, you folks listening in the Sunflower House with me, to be strong, be healthy, and be in charge. So that's true of all of our podcasts. So in terms of this question, I responded that the vast majority of research does support resistance training as an effective means to increase bone density. And many people can use weighted vest with other resistance exercises, but it comes with a strong recommendation that you use it with caution and as tolerated. And if you strap in weights that are too heavy, it actually could increase your risk of spine compression fractures, which the spine just collapses on itself with either wedge fractures or crush fractures and causes that dowager's hump you see in so many older people. So it's important to always get individual advice and guidance from your physician or your healthcare team. And sometimes I tell women who have very severe osteoporosis to avoid any crunching of the spine, weighting of the spine, Pilates, intense abdominal crunches, until they've been treated for at least 6 months and we've stabilized that excessive bone breakdown. And many times I actually refer women to special physical therapists who can do balance exercises to reduce falls and assess the person's muscle strength and balance and come up with an individualized program. And I would recommend that our listeners who are interested in osteoporosis exercises go on our website, speakingofwomenshealth.com, because we have a lot of great information. Now, various health systems that have robust exercise programs can recommend a vest, a weighted vest, equaling 5 to 10% of your body weight. But you must wear supportive shoes. You got to protect those feet and knees and ankles. And it's also important to know that your muscles do need a day of recovery in between your workouts to repair and regenerate. It's also important to get enough dietary calcium. And I always recommend a separate vitamin D3 with K2 supplement, particularly for people over 40 who live in northern climates. Now, I did an entire podcast, episode 3, season 1, on vitamin D. And since I did that podcast, there's been further interesting research on vitamin D showing that the goal vitamin D level is about 75 for hair. And I know women are very interested in hair. Last season's podcast on hair thinning was the number one listened to podcast. And I kind of mused, well, hair thinning or hair loss is not going to affect your independence or your longevity, but osteoporosis will. So, we try to cover all different topics. And I'm going to do an updated podcast, probably posting around Father's Day, since hair thinning is not just for dear old dad. So if you want to hear more about hair, tune into that. The other research that came out with vitamin D showed that people who had levels of 125, even back in the early surges of COVID, when the original strains and the Delta strain were very lung trophic, didn't result in any hospitalizations. Now, if you get levels of over 150 or 200 for prolonged periods of time, that could cause some hypercalcemia. So again, we're not recommending mega doses of anything, but I really like to shoot for a vitamin D level of 50 to at least 75. Now, if you've not done so already and you've got a family history of hip fracture or osteoporosis, or you're a postmenopausal woman or someone who's had risk factors, you've maybe had prior eating disorders, maybe you've been on prednisone or steroids, maybe you have a seizure disorder and you've been on anticonvulsants, which can affect vitamin D metabolism, or you've had thyroid disorders, you do want to check in with your a specialist that is interested in bone health. That could be your primary care doctor. It could be your gynecologist. It could be a specialized women's health trained physician like myself, who's trained in several different areas. Many endocrinologists and some rheumatologists are also interested in osteoporosis. And in some countries, actually like in Japan, the orthopedic surgeons that treat surgically the fractures do treat osteoporosis. But you need a whole team approach. A physical therapist might be able to advise about special exercises. And even with the calcium, the vitamin D, the exercise, the fall prevention, the weight-bearing exercise, those are all hygienic lifestyle. It's not treatment for a disease. So if you're actively breaking down bone, all those lifestyle things are quite important, but they're necessary but not sufficient. And as I mentioned, make sure your bones are stabilized before you embark on an increasing exercise regimen. Moving on to our second question. I had a bone density recently, and I was told I have osteoporosis. And I just started alendronate, which to our listeners, alendronate is the first oral bisphosphonate that hit the market in 1995. The brand name was Fosamax, and now there's probably 20 different generics. So this woman asked, in addition to walking, rowing, and using my ellipticals, what else can I do to strengthen my bones? So my general answer is, of course, consume enough dietary calcium, like about 1,200 milligrams per day. And please check on our website for the calcium calculator. But it's important to note you only absorb about 500 milligrams at a time, so you need to divide your daily dose between several meals. Now, many of my patients are doing intermittent fasting because intermittent fasting is anti-aging, it reduces diabetes, it reduces insulin, it helps with weight loss, and many other conditions. And so a lot of my patients say, well, I only have 2 meals. Well, maybe you're only eating in an 8-hour time period, you have 2 meals, but like in the middle of those 2 meals, you could have a little snack, such as a piece of cheese or a little bit of milk or almond milk or some almonds that have calcium. And we list foods that are rich in calcium, and I've certainly done a podcast on cheese last season, and also calcium and blood pressure and cholesterol. So generally, low-fat dairy products are excellent. Some green leafy vegetables, some beans, salmon, mackerel, tuna. You can get your calcium and your omega-3s in some of these foods. Broccoli. I like to put cheese on top of broccoli when I serve it. And my son always grouses. You're always putting cheese on things. And you know what? My sons have really strong, dense bones. And their cholesterol and blood pressure and all of that is good as well. There are non-dairy milks if you're allergic or can't tolerate dairy. Sometimes people do need calcium supplements, particularly if they avoid all dairy or they're on a restricted diet. Now, weight-bearing exercises are important, healthy lifestyle, both cardiovascular aerobic training as well as weight-bearing training. We like at least 30 minutes of weight-bearing exercise 3 to 4 times per week minimum. We do want you to maintain your strength, and after age 45, people tend to lose muscle mass and get a slower metabolism. Avoid smoking, nicotine. Avoid excessive amounts of alcohol, which are bad on the bone. And caffeine, anything more than 2 to 3 cups a day causes you to lose more calcium in your urine. And sodas, these high phosphorus drinks should be really avoided. Now, make sure to take any prescription osteoporosis therapies prescribed by your physician or APP. Keep your follow-up schedule appointments. And many times bone scans and bone densities are recommended 2 years in advance. Like I can't order anything more than 1 year in advance. So I tell my patients, get out your trusty smartphone and put it in your schedule for a couple years out. And then give yourself a reminder 6 months in advance that you need to schedule that appointment. The next question are, what are some food choices that can strengthen my bones? Well, we talked about all those calcium-rich foods, but you need to not just focus on calcium and vitamin D and think that you're done, or a healthy lifestyle. And I see very healthy women who've checked all those boxes off, and they still have osteoporosis, and they still need treatment. The next question is, how often should a woman, I happen to be 64, she tells me, have a bone density? Well, the standard recommendation is certainly everyone that's a female should have a bone density by age 65, and probably men by age 70, if not at risk for fracture. If it's normal, we can repeat that in 3 to 5 years. And the dual energy X-ray absorptiometry is used to check the bone density, usually in the lower spine and the non-dominant hip. Once you're 65, we do both hips because the spine has a lot more arthritis. Sometimes we do the non-dominant lower 1/3 of the wrist, particularly if we're worried about hyperparathyroidism, or we have some patients who've had both their hips replaced from fracture, so you can't scan their hips. And after 65, a lot of times arthritis or atherosclerosis sets in and makes it more difficult to evaluate the spine, or some people can't even get that trabecular bone scoring I mentioned earlier if they have spine hardware. So then we're just left with the forearm. So risk factors for fracture include a prior fracture over age 40, cigarette smoking, any long-term prednisone steroid use. So that's about 7.5 milligrams of prednisone for 3 months. Low body weight. Or if you've already been diagnosed with osteoporosis. And certainly people that have family histories of hip fracture we're very concerned about. Now, we had talked about all the lifestyle issues, but if you do have osteoporosis, you're going to need to talk about therapies. The next question talks about my physician just started me on alendronate, that Fosamax. And what's the latest information on this medicine, short-term and long-term? And I've had bone density done about 4 years apart, but my doctor says since I have a family history of osteoporosis and I have a change in the thinning of my bones, that I am still at risk for fractures as I age. So my answer is that alendronate Fosamax belongs to a class of medicines called bisphosphonates, and they're both used for the prevention and treatment of osteoporosis at varying doses. Ibandronate or Boniva was the first one to come out in a monthly tablet. And since these tablets have to be taken upright on an empty stomach and with just plain water and no other vitamins or supplements, the people, like the convenience of doing something once a month. But I caution that you only have 12 times a year to get it right. So you don't want to be flushing your medicine down the toilet. Now, Residronate or Actonel comes in a daily dose, a weekly dose, and 150 milligram monthly dose that I use frequently, and is approved to prevent glucocorticoid-induced or treat GIO, glucocorticoid-induced osteoporosis. Now, Atelvia, which is a form of Residronate, is the only one that can be taken with food. And alendronate Fosamax, for people who can't swallow tablets, does come in a liquid form. And there's 2 doses of weekly alendronate Fosamax, either the 35 milligram weekly dose for prevention or the 70 milligram dose once a week for treatment. And a lot of times to reduce cost of medicines, I give higher doses and just dose them less frequently, like 70 milligrams twice a month for prevention. Although most of these medicines are generic and not too expensive. But some of the osteoporosis medicines are very expensive. And if you haven't heard our prior podcast or read our column that our nurses have done on Speaking of Women's Health on how to save money on medicine, please go to the website, put the word money, M-O-N-E-Y in, and there is just such a plethora of great tips. Now, the alendronate increases bone density and does decrease the risk of fractures for at least a decade or more. Some of the common side effects can be stomach upset or GI. People who can't swallow correctly or get the tablet into their stomach cannot take the medicine. If there's kidney insufficiency, this is cleared by the kidneys, so we would not recommend it. And the manufacturers generally recommend being upright for 30 minutes. I recommend 60 minutes, as well as avoiding eating or drinking anything for 60 minutes. And don't go on your inversion table if you do that in the morning, like I do, for at least more than an hour, maybe just skip it the day that you take that monthly tablet if you're on the Residronate. The next question is, I don't have a family history of osteoporosis, so do I need a bone density? And the most accurate way of measuring your bone density, which requires very little radiation, is a bone densitometry. And your physician can determine what your risk of fracture is based on your age, other factors, as well as the bone density. And if you're able to get that trabecular bone scoring done, that further helps specify what your risk is. Now, age is a big risk factor. So anyone under the age of 60, even with bad bones, doesn't always rate high enough for immediate risk. But as I tell my patients, when I'm seeing you, I'm not just treating you for when you're 55. I'm thinking about when you're 65 and 75 and 85. So these cutoffs that your physician, if your physician's not an osteoporosis specialist, might say, well, you don't fit into that high risk category. If it's because you're young, it doesn't mean that you still don't want preventive treatment. And there is a direct relationship with the lack of estrogen and rapid bone loss in half of all women. And rapid estrogen loss happens to all women if they live long enough and go into natural menopause. And if you've had early menopause or premature menopause or surgical menopause where your ovaries have been taken out, you're at even greater risk. So we would want to do bone density sooner in those women. The next question, am I at risk for osteoporosis if I'm thin and tall and I've also been taking thyroid hormones? You know, thyroid problems are very common in women. I hope you've listened to our podcast on thyroid problems, where I interviewed a thyroid expert and endocrinologist, Dr. Ula Abed. So osteoporosis does have many non-modifiable risk factors, including advancing age, previous fracture as an adult, prednisone steroid use, a mom or a dad who's had a hip fracture, being low body weight, current cigarette smoking, excessive alcohol. Also, rheumatoid arthritis increases the risk of osteoporosis twofold. And there's some other medical conditions that your physician can evaluate you for. Some are reversible, like untreated celiac. I've seen people with osteoporosis, once they're diagnosed with celiac and they take that gluten out of their diet, have their bones get much better. Hypercalciuria, where your kidneys leak out too much calcium, can increase the risk not only of kidney stones, which we've talked about in a prior podcast, but also osteoporosis. So getting back to this lady, the fact that she's been on thyroid medicine generally doesn't put her at increased risk as long as her TSH was controlled and she was not on excessive thyroid. But sometimes I do see women on excessive thyroid. They're taking the armor-based animal thyroid, or they're just taking too much and not getting managed and measured. Yes, being underweight does put you at increased risk for osteoporosis, particularly if you've had eating disorders or anorexia, or you've been so thin that you didn't have enough body weight, hence your menstruation shut down prematurely, which happens to certain athletes and certain types of sports, more likely gymnastics and ballet, where being very thin and light is emphasized. Typically, we do a bone density by age 65, but we can do it within 2 years of menopause, particularly if that's going to affect your decision about hormone therapy. Now, most women benefit from hormone therapy, but not all have symptoms or want to do that. And a few have contraindications. And we've certainly in prior podcasts at the beginning of season 1 covered the exciting class of non-hormonal candy neuron inhibitors, of which we have Veosa, fezolinetant, but that treats hot flashes but doesn't treat the bone. And I have a lot of women on hormone therapy that then they stop it for whatever reason and they forget that we were also using it to treat their bones. The next question is, I have a lot of bone loss in the last 2 years. I went from having osteopenia on bone density to osteoporosis. And this seems so fast, especially since I'm a regular exerciser. Well, my answer is it's not uncommon for women to lose bone rapidly once they enter menopause. Normally in the first 5 years to 7 years, the rate of decrease can be 3% or more per year. And after the first 5 years, it can be about 1%. I've seen women lose 20% of their bone mass just within a handful of years after menopause. Usually the lumbar spine is the first to be affected, and that's why we see more wrist fractures and dowager's hump before we see the hip fractures. Certainly women that go into menopause at an earlier age are a concern. And if you're someone that has normal bone density at your hip, but very low in the spine, your FRAX score is dependent, your risk of fracture in the next 10 years, which we calculate, is based on the hip bone density. So a lot of times I won't even report out the FRAX if it makes it look like you're at a lower risk than what I think you really are. Now, you should speak to your physician about looking at secondary causes of osteoporosis. We did some seminal research in the Center for Specialized Women's Health, led by Dr. Andrea Sykon, who's the chairwoman of our general internal medicine large department at the clinic, and she won a research award on this. And we found out that just looking at simple chemistries, a 25-hydroxy vitamin D, a thyroid test, and doing a 24-hour urine calcium, and having a low index of suspicion of doing a parathyroid hormone level in women who had an elevated calcium, all helped pick up secondary causes without much expense. If you have thyroid disease or kidney stones or GI problems, then you might definitely need some further evaluation. Get the calcium in your diet and separate vitamin D. Doing exercise is important, but you generally, if you have osteoporosis and you have bone loss, you do need treatment to reduce that. And there are some blood tests that we can do to see if you're rapidly breaking down bone, and then recheck that after you've been on bone therapy, because in general, we have to wait 2 whole years before we do another bone density. The next question is, can I switch my osteoporosis medicine? And that's something you have to talk to your osteoporosis specialist about. Some women might be on Prolia denosumab, which is a sub-Q shot given by the nurse every 6 months plus 1 day. If you're failing and breaking bones, we might switch to an anabolic bone building agent like teriparatide Forteo, which has to be refrigerated, or abaparatide, which is Tymlos. Abalaparatide. I'm getting a little tongue-tied with these PTH analogs. But Tymlos does not have to be refrigerated, and it's injected kind of similarly to an insulin pen, and the cartridge has 30 doses in it if it's Tymlos, and it has 28 doses in it if it's the refrigerated Forteo. But if your own PTH is elevated, you might have something wrong with these 4 glands in the neck, the parathyroid glands. You can have an adenoma. You might have secondary hyperparathyroidism from a low vitamin D state, which is so ubiquitous if you're not on supplementation. Checking for celiac disease and multiple myeloma. If your phosphorus level is really low and your B6 is high, you might have hypophosphatasia, a rare condition that requires an expensive enzyme treatment. The next question is, what does it mean if a reading suggests secondary bone loss? Well, that's very important for your doctor to definitely evaluate you. It means that other than just age and menopause and genetics and aging, that you may have other medical conditions. And that's if compared to your own age-matched, weight-matched peers, your Z score, not the T, but the Z, is more than 1.5 standard deviations below normal. So rheumatoid arthritis and premature menopause and kidney failure and type 1 diabetes, testosterone deficiencies and celiac and hypercalciuria all can be secondary causes. The next question is, what osteoporosis medicines are the most effective with little side effects? Well, that depends on the individual person and their treatment plan. Generally, the oral bisphosphonates like alendronate and risedronate and ibandronate are generally simple to dose, generic, affordable. They've been available since the 1990s. We have solid safety data we can safely use for a decade, as long as there's no renal insufficiency. But if you've got stomach upset or gastroesophageal reflux, or if you don't remember how to take it correctly, or if you've had intestinal or gastric bypass surgery, we probably would want to go straight to intravenous bisphosphonates like Reclast. The generic is zoledronic acid. Zometa is a brand name of zoledronic acid that many times is given a few times a year to women being treated for breast cancer because it's good for breast cancer and it protects the bones. And a lot of women with breast cancer who are estrogen positive have to be treated with therapies that reduce estrogen at the cellular level, which is really bad on the bones. The nice thing about intravenous Reclast is you can get it in a 30-minute infusion. It's generic, it's highly effective, and it can be used for several years. I many times will use it every year for 3 years if someone has osteoporosis, reassess them and maybe use it every other year to every third year after that. It can be used up to every year for 6 years in a row, but in another study where people got it 3 years in a row and then nothing else for 3 years, that group fared almost as well as the group that got it every year. It's nice because you can vary the timing of the dose, whereas Prolia, once you get Prolia, you can't just abruptly stop it without other treatment, or there's a really high risk of rebound fractures. Now, Prolia is nice because it doesn't go through the kidneys, so anybody with kidney impairment, that's a nice option. The cons are you do need to come in, see the nurse, and have an intravenous IV line placed. And the first infusion, about 10 to 15%, can develop flu-like reactions, but usually Tylenol, acetaminophen, Advil, ibuprofen, hydration, and making sure that your vitamin D level is well over 32 to start with will help. If it's under 30, the nurses won't infuse you at our center. Now, I think one class of medicines which is very generally easy to tolerate and not expensive and generic and has other benefits like reducing breast cancer and helping cholesterol levels is the selective estrogen receptor modulator Evista raloxifene. It's a daily pill, doesn't upset the stomach, doesn't have to be taken on an empty stomach with nothing else for an hour like the bisphosphonates, and it's known to reduce the risk of estrogen-positive breast cancer by 50%. And it's an excellent choice if you only have spine thinning and you don't have hot flashes and you're not on estrogen, whether or not you have a family history of breast cancer. It does not reduce hip fracture, though, and there's a slight increased risk of blood clots if you're at bed rest, like having a hip surgery or knee surgery. So I tend to use hormone therapy first because it treats symptoms and prolongs life. If a woman's not on hormone therapy or she stopped hormone therapy and she just has spinal osteopenia, I use a lot of Evista raloxifene. As a woman gets older, or if she's on steroids, prednisone, or at a higher risk for hip fracture, I use the bisphosphonates. Now, one of the hormone combinations that we were very excited to have that was off the market during the whole pandemic that just came back in June of 2023 is Duave, which is conjugated estrogens with basidoxifene, which is a SERM. And it's a daily pill that treats menopausal symptoms, protects the uterus, and seems to have a lower side effect profile and has, for women who have any kind of breast tenderness with any progesterone or progestin. But it, like any hormone regimen or raloxifene Evista, can increase blood clot risk. Now, the subcutaneous human monoclonal antibody, Prolia, came out in June of 2010. So I gave the first injection at the Cleveland Clinic, and I've had patients on it now for 14 years. And it was studied for a decade before it hit the market. And it's the natural human monoclonal antibody that women tend to not make once they go into menopause. But it only lasts for about 7 months. So you really have to get your injection every 6 months plus a day. And you have to come in and keep your appointments. And sometimes I see women after several years, their bone density is better and they just kind of fall off the schedule. And many times I hear back from them because then they have a bone fracture. So if you're on Prolia denosumab, you can't just stop it. Usually it's reserved for women at highest risk of fracture, or only for people with renal failure or intolerance to other factors. And if you have renal insufficiency, you're at higher rate for hypocalcemia, and that's a boxed warning that has to now be addressed. I would say if you're on one of those Medicare Advantage programs or you switch your Medicare secondary, I've had some women who've had coverage for Prolia that all of a sudden it's covered, but it's too expensive for them to afford. So, something that's covered, but is still very expensive is sometimes makes it out of your reach. And if you have not heard the podcast in season 1 I did with that expert on picking a secondary insurance for Medicare, you should definitely listen to that. Now, if you're going to go on an anabolic daily shot to boost your bone growth, you have to learn how to give yourself an injection for at least 18 months to 2 years. And we do have those PTH analogs, Forteo and Tymlos. And once you're done with that 2-year treatment, you're not done, because even though you've built bone up, you have to follow it with either the intravenous reclast or the twice-a-year Prolia if there's any renal insufficiency, or you're going to lose all that bone you built. And we generally do not use this in women who have Paget's disease or any person who's had radiation. And a lot of women with breast cancer might have had chest radiation. It is well documented that hormone therapy, either oral or by patch, with or without the tissue-selective estrogen complex basodoxifin, helps prevent progression to osteoporosis and also reduces falls. And women that have hot flashes and night sweats and vaginal dryness, and they want to protect their bones and their joints and their skin and their hair, it's really a great option to use hormone therapy. But hormone therapy only protects the bones as long as you're on it. So once you go off of it, you're at risk for rapid bone loss, just like you were when you maybe hit menopause at age 52. So that rounds up our question and answer session in this podcast on osteoporosis. Thanks for joining me. And again, if there's a topic you want to hear about, go on the Contact Us. And if you enjoyed listening to this podcast, please give us a 5-star rating. Share it with friends. You can also go on our website and make a donation to our nonprofit. Even a $10 donation is so much appreciated. And you can subscribe on Apple Podcast, TuneIn, Spotify, wherever you listen to podcasts, even on YouTube. You can go on our Rumble channel and watch our interviews. And I'll look forward to seeing you again in the Sunflower House.